Hello and welcome to Applied Pharmacology for veterinary technicians. We're going to start chapter 1 by talking about general pharmacology, and then we're going to move into just some more uh, detailed things. So there will be a part 2. It just helps us to split up the time a little bit. You do have a list of key terms with definitions in your eLearn course shell. I can't stress enough to you how important it is that you understand each of these words and what their definitions are, at least basically. You should be able to understand the difference between an adverse drug, what an agonist versus an antagonist is, what compounding means, what drug is, efficacy, extra label use, half-life, manufacturing, how do we manufacture drugs, metabolism or biotransformation, parenteral. Absolutely need to know what parenteral means. Partition coefficient, prescription or legend for the drug, residue, the veterinary client patient relationship. If you don't understand that one, you're going to get into a lot of trouble. And then also withdrawal time. So these are some key terms we'll talk about in this chapter. You need to go through those definitions. You need to have them on hand as you go through your chapters. One of the important tasks that veterinary technicians carry out is the administration of drugs to animals on the order of a veterinarian. Remember, you cannot prescribe the medication, but you do give the medication, and often you can catch things if you feel like the dosage is wrong or if there's something going on with that medication. It has serious consequences in terms of the animal, the outcome of the case, and it's mandatory that technicians have a thorough knowledge of the types and actions of drugs used in veterinary medicine. You should have an understanding of the reason for using drugs called indication. So when we say, oh, this animal has pneumonia, this drug is indicated for pneumonia, we're going to use this drug. But we also need to know what contraindications are. So if the animal has pneumonia, then this drug is contraindicated. And you should know those contraindications as well because you're going to save an animal someday. So that's called pharmacotherapeutics. There are 5 rights to administration. So basically, you need to make sure you have the right patient, giving the right drug. Check that label 3 times before you administer the drug. The right dose, the right route, and the right time and frequency. If you've ever been in an ER or a hospital or even at the doctor's office, they will check your name, check your birth date, check the drug, and do that check with you 3 times and make sure you understand what you're taking before they give it to you, often many times a day. So it is really important that you do that for your animals. We do need to know the difference between the word pharmacokinetics and pharmacodynamics. Kinetics means how they enter the body, how they move. Kinesthesia, movement through the body. Pharmacodynamics means how do they affect the body? What changes do they cause? And then adverse drug reactions manifest themselves as typically a toxicity. We can have adverse drug reactions based on the physiology of the animal's body, but most of them are due to the fact that we're not administering the medications correctly. Because we dispense a large number of drugs, you need to be versed in the components of a valid veterinary client-patient relationship. If we do not have a valid veterinary client-patient relationship, that means that the client has been seen or the patient has been seen and communicated with the veterinarian within the last 6 to 12 months, depending on the medication, then we cannot dispense or prescribe medication to that animal. We have to understand how do we label dispense products and in order to comply with laws, federal laws and state laws. And then how do we educate the client on how they use the product to avoid any toxic effects or residue. With pharmacotherapeutics, veterinarians are challenged by the task of assessing a patient in order to determine a diagnosis and arrive at a plan of treatment. When we use this diagnostic method, we need to assess the patient, including history and physical exam, do laboratory tests, other diagnostic procedures to arrive at a specific diagnosis. Once that diagnosis has been determined, then we can determine the causative microorganism or that altered physiologic state that allows the selection of an appropriate drug. So when we do pharmacotherapeutics, most of the time we should be doing the diagnostic method. The empirical method of pharmacotherapeutics calls on the practical experience and common sense when a drug choice is made. So if we cannot do a lot of diagnostics, which is really important, and we need to educate our clients on how important that is, then we turn to the empirical method. Basically, it's my understanding of medications, understanding of the disease process that I think is going on, uh, that helps me to make that drug choice. So I have to have experience and a lot of knowledge. In veterinary medicine, the comparative cost of a drug is also an important consideration when we select the appropriate drug. Once the drug to be used in treatment has been decided, then we have a plan for administering the drug. That's called a regimen. That tells us the route of administration. Is it peros, by mouth? Is it IV? Is it IM? Is it IP? Is it transdermal? Gives us the amount to be given, which is our dosage, or dose. Actually, it's our dosage rate, which is our dose. How often the drug is to be given, the frequency, and how long it's going to be given, the duration. So all of that together is dosage. The dose is the actual thing that I'm giving, the milligram strength that I'm giving at that time. When we've selected the drug and the regimen, then the veterinary technician is the one that's typically given verbal or written orders to administer the drug. So here are your responsibilities. Make sure it's the correct drug, administer it by the correct route at the correct time, observe the animal's response to the drug, question any medication orders that are not clear or do not make sense. As veterinarians, we do make mistakes, and it is important that you question for the safety of the pet. Create and affix labels to medication containers accurately. Explain the administration instructions to the clients, and record all of that information in the medical record, including the instructions you've given to the clients. So pharmacokinetics, this is the movement of drugs through the body, and it's a complex sequence of events that occurs after the drug is administered to the patient. So if we give it, for instance, rectally, it's going to go directly into the intestines. Once it's in the intestines, it may go to the liver, or it could stay in the intestines and go through the feces and be excreted. If we give it orally, it's going to go into the stomach, which is then going to go be absorbed and either go into the intestines or the bloodstream. If it's in the intestines or the bloodstream, it's going to go to the liver. The liver also feeds back to the bloodstream. So if a medication is biotransformed in the liver, we have a recycling of that drug through the bloodstream. And that is something we need to be aware of. It goes both ways. Once it's in the liver, it goes into the feces through the bile ducts in the gallbladder, becomes bile, and gets in the feces and is excreted. If the drug is inhaled, it gets into the bloodstream right away. If it's a plasma-free drug, it's going to either go into the liver and be biotransformed, maybe go back to the bloodstream, or the metabolites are going to go into the kidneys and be excreted through the urine or breathed out through the lungs, as happens with anesthesia. Can go into the mammary glands, the sweat glands, and the salivary glands. It depends on the drug. A protein-bound drug is going to change where it is. So if there's not enough protein, it's going to stay in the plasma. If there's enough protein, it'll go and become protein bound, and then it will go to the tissues, just be distributed to the tissues. Okay. Let's see. Parenteral administration. So if we do outside of the intestinal tract, parenteral. If we do IV, it goes directly into the bloodstream. If we do IM, it needs to go through absorption in the muscles or subcutaneous through the bloodstream. It takes a little bit longer. Okay. The site of action is these tissues. So we need to remember that pharmacokinetics, if you can see these blue words here, this is absorption, biotransformation or metabolism, and excretion. Absorption, distribution, and excretion. Okay, there is biotransformation happening in the parenteral administration as well. Remember, this goes both ways, but we get faster distribution here. So once it's been given, it's available for absorption into the bloodstream, and then it needs to go to the site where it will exert its action. After a drug is absorbed, it's distributed to various fluids and tissues in the body. It's not enough for the drug to simply reach the desired area. It has to accumulate to the right concentration in order to be effective. So that's why we need to take it to that dose that is affected. Because the body immediately begins to break down and excrete the drug, the amount available to the target tissue is going to become less and less over time. If we need a drug to get to a higher blood level sooner, we're going to administer a loading dose first. This is a higher dose that will get the concentration at the tissues to that level that we need at a quicker time period. Then the dose is going to be reduced to an amount that replaces the amount that is lost through elimination. So we give a loading dose, and then we give a maintenance dose just to keep it at that level as the drug is excreted. Doses of other drugs are at replacement level throughout the regimen, and in some cases it does take time to get that drug to that concentration, and we want to keep it at that concentration and have it accumulate at the same level that the drug eliminates, so steady state. So how do we know how to do that? That's where drug trials come in. That's where research comes in. If we underdose, we're going to have less than effective levels in the tissue, and if we overdose, we're going to have toxic levels in the tissue. We can measure drug levels in the blood, in the urine, in the cerebrospinal fluid, and any other appropriate body fluids that we know that the drug goes to, so that we know that the appropriate level has been achieved. Non-steroidal anti-inflammatory drugs, cardiac drugs, anticonvulsants, and thyroid drugs are commonly monitored because these are often drugs that are given for a long period of time, or if they are given for a long period of time in the case of chronic pain. We want to make sure that the metabolism is not changing and we're not eliminating the drug too quickly or too slowly, and so that we don't have to adjust the levels. So if you know anything about animals on chronic medications, you'll know that we usually test their blood and the levels of those drugs, or how those drugs are affecting specific tissues like the heart or the liver every 6 months or so, sometimes more frequently. So here's an example of a chart of plasma or tissue concentration of a drug over time. So we give the medication. If we give too high of a dose, it can become toxic in a very short period of time. If we give the right amount of dose, here is our therapeutic level. It's going to stay within the therapeutic level, but again, over time, it's going to start to decrease. If we give less than the correct amount of drug, we're never going to reach that therapeutic level, and it will decrease a little sooner. So what we need to do is we need to give doses, give therapeutic doses at specific amount of times, knowing how quickly we eliminate that drug. So if this is a drug that we eliminate fairly frequently, we're going to give that drug more frequently. You know that we have drugs that are to be given once a day versus twice a day versus 3 times a day versus 4 times a day. And we also know that the more often you have to give a drug, the less likely that the animal is going to get the optimal or therapeutic dose of the drug. So we need to try to look for those drugs that are given once or twice a day. So primary factors that influence blood concentration levels of a drug and a patient's response to it include the following: the rate at which the drug is absorbed, the amount of the drug that is absorbed. So some drugs are not completely absorbed. Some parts of the drug may be excreted before they're absorbed. The distribution of the drug throughout the body, the drug metabolism or biotransformation and how long that takes, the rate and route of excretion. Drug absorption is the passage of a drug from the site of origin into the bloodstream. Before drugs can reach their site of action, they must pass through a series of cellular membranes that make up absorptive surfaces of the sites of administration. Now, if at any point you're like, I don't understand, how are these drugs going through cellular membranes? I do have a video for you in your learning activities in that Explore. It's a fairly short video that will kind of, it illustrates how this happens. So take a look at that. So the degree to which a drug is absorbed and reaches general circulation is called bioavailability. So the higher the bioavailability, the higher absorption rate that you have. We want a high bioavailability most of the time. There are some that we do not actually want to have high bioavailability because we want them to stay where we put them. Drugs that are administered into the blood supply do not have an absorption phase. They're right where we want them. They do have to go through the cellular membranes to get in the tissues, but when we talk about bioavailability and absorption, we're talking about getting into the blood supply. So there's no absorption phase in this. They get in there very quickly. Drugs that are designed to have poor or no bioavailability, drugs that we want to stay and not get absorbed into the bloodstream. So if you can think of any, give you just a second. We're going to talk about this in class again. But for instance, things that we want to stay in the GI tract. We don't want it to be absorbed into the bloodstream. Something like sucralfate, which is the drug that coats the intestines and helps those intestines to be soothed. Okay. The manufacturing process can have a significant effect on the physical and chemical characteristics of a drug molecule, and that influences their bioavailability. Because of these manufacturing differences, the generic form of a drug may differ somewhat from a trademark form in overall efficacy. So we always want to try the trademark form first. If it's working, let's go to the generic form, and if it works as well, then we're good. Bioavailability is often demonstrated with the use of a blood level curve. So just like we saw before, we have blood concentration and the hours after a drug administration. And this is the time required for peak concentration. So at 2 hours, we have peak concentration. So if I am looking to see what the highest level of the blood is in that animal, or the drug is in that animal, I want to go at 2 hours with this drug. And I'm probably going to need to remedicate this animal every 4 hours to knock it back up, right? So we have to watch that. Drug absorption. So there are factors that affect the absorption process, and they are the mechanism of absorption, the pH and ionization status of the drug. So we actually have to look at that. The absorptive surface area. So where are we putting the drug? And how absorptive is that area? For instance, in the GI tract, we have a lot of absorptive surfaces in that GI tract. So there's a lot of places where it can be absorbed through the intestinal membranes and into the blood. However, if we have a swollen GI tract, we are actually lessening those absorptive areas and making it thicker so the drug can't go through as well. So it will decrease our bioavailability. We also want to know what the blood supply is to the area. If we have low blood supply to the area, the drugs aren't going to be going to that, aren't going to be getting into the blood. The solubility of the drug, so we need to know if it's lipid soluble or fat soluble, and we'll talk about the difference between that in a second. The dosage form, the status of the GI tract, like I said, the motility is a factor, so how quickly it moves through the GI tract, permeability, the thickness of the mucosal epithelium, and then interactions with other medications. Some medications act to decrease the effectiveness of other medications, and some actually act to increase the effectiveness. Drugs pass through cellular membranes through three common methods. There's passive absorption, which is transport by simple diffusion of a drug molecule from an area of high concentration to on one side of the membrane to an area of lower concentration on the other side. So there's no energy expenditure by the cell. And again, I have a video for you to kind of illustrate that. The drug can pass through small pores in the cell membrane or dissolve into the cell membrane on one side and pass through the cell membrane and exit on the other side. For example, a disintegrated tablet or capsule results in a high concentration of drug in the GI tract. This concentration then passes through the cellular membrane of the intestinal villi and adjacent capillaries, and the drug then appears in lesser concentration in the bloodstream. Some small drug molecules, such as electrolytes, can simply move with fluid through the pores in the cell membranes. Active transport of drugs across cell membranes moves molecules from an area of lower concentration to an area of higher concentration. That actually requires the cell to use energy. And that's the usual mechanism for the absorption of sodium, potassium, and other electrolytes. So remember, we have our sodium potassium pump, right? And that pump does require energy. Physical transport requires energy. So when a cell engulfs the drug molecule, that requires energy. And we call that phagocytosis, is when a cell eats. And a pinocytosis is when the cell drinks. And this is not as common as the other two methods. Many drugs pass through a cell membrane only if they're non-ionized, so they're not positively or negatively charged. As the absorptive surface of the area of drug placement increases, so does the rate of absorption. One of the largest absorptive surfaces in the body is found in the small intestine because of the efficient design of those microvilli. Remember those microvilli, there are a lot of little bumps within the intestinal tract that maximize the surface area. At any site of a drug administration, as the blood supply area to an area increases, so does the rate of absorption of the drug. Drugs are absorbed from an intramuscular site at a rate faster than subcutaneous site because there's more blood supply to the muscle. If we initiate a fight or flight response that increases blood flow to the muscle but decreases blood flow to the intestines, we have to keep that in mind. If we have a stressed out animal, they're not going to absorb the drug through the intestines as well as they will absorb the drug to the muscle if we give it in IM or through the muscle. Heat and massage also increase blood flow to an area. So if we have poor circulation, if we have shock or cardiac failure that decreases blood flow, or cooling or elevation of a body part, we may want to use heat or massage to increase blood flow to that area and carry the blood where it needs to be. So they can positively or negatively influence drug absorption. That's why when we did the case study on the giving the doxorubicin extravascularly, one of the things to do was to put a cold compress. That's going to decrease the blood flow to that area so that that drug is not going to be absorbed into the tissues. Another important factor that determines the rate at which a drugs pass through the cellular membrane is the solubility of the drug. Lipid fat solubility of a drug tends to be directly proportional to the degree of drug non-ionization. Remember that non-ionized form is the one that is usually absorbed. Lipid soluble drugs are usually absorbed. And those two things go hand in hand. The degree of lipid solubility of a drug is often expressed as its lipid partition coefficient. A high lipid partition coefficient indicates enhanced drug absorption. So a drug that is highly lipid soluble has a high lipid partition coefficient. It is also likely non-ionized. Drug absorption rates often depend on the formulation of the drug. Remember, manufacturing of the drug. So there are some inert ingredients such as carriers or vehicles binding agents, coatings, these are all used to prepare dosage forms. These substances do have major effects on the rate at which formulations dissolve. If we have, so these are different formulations of drugs. We have a capsule here. We have a buffered tablet here. This looks like ibuprofen. There's some more coatings on here, and they're going to delay the absorption of the drug because it takes time to break these down. Now, based on the chemical ingredients or the inert ingredients of this, will tell us how quickly that capsule that covers the drug will be broken down. These are little microcapsules, so even within a capsule we can have little microcapsules which even further delay the breakdown of the drug, which can be really helpful if we want that drug to stay in the system for a long period of time, because we can actually manufacture these to be broken down at different times, so you get a constant rate of infusion of that drug in your system, but given orally. The process of combining some drugs with other drugs can have, or even foods, can have a negative effect on drug absorption. Here's an example. Tetracycline is reduced. We cannot absorb tetracycline if we give it with milk or milk products because calcium will bind to tetracycline. Antacids also reduce the absorption of phenylbutazone or iron products. And you have to know what these drug interactions are when you are prescribing medication. So you want to consult those appropriate references and identify those potential interactions when you're administering new drugs. So that was drug absorption. Drug distribution is the process by which a drug is carried from its site of absorption into the bloodstream to its site of action. Drugs move from the absorption site into the plasma of the bloodstream, out of the plasma into the interstitial fluid that surrounds the cells, and then from the interstitial fluid into the cells where they combine with cellular receptors to create an action. We have an absorption site that goes into the plasma, into the interstitial fluid, outside from the capillaries, into the cells, and then we have our action. So it's a lot of membranes there. Drug distribution establishes an equilibrium. So this is the volume of diffusion. So this equilibrium is maintained between this amount of drug at the site of absorption, the amount in the plasma, and the amount at the cellular receptor sites. We have absorption going into the plasma, and then it goes into the interstitial fluid and out of the interstitial fluid back into the plasma. It hits the cellular receptors in the tissue. From the plasma, it goes and is metabolized or biotransformed in the liver, and then we have excretion out. Okay. Sometimes, let me go back here, sometimes this metabolism actually goes the other direction and we have a recirculation as well, and we do have to watch for that. Drugs that are highly lipid soluble tend to move readily out of the plasma and into the interstitial fluid. Drugs in the non-ionized form follow a similar pattern. Once a drug is present in a tissue, it can become bound or stored there. Tissues such as fat, liver, kidney, and bone can act as storage sites for drugs such as barbiturates, inhalation anesthetics, and others. So if an animal is obese and it's storing these drugs, it will allow it to be dispersed over time, which can prolong anesthesia. When a drug moves out of storage tissue back into blood, and additional doses are given, an exaggerated or prolonged effect can result because of additive effects. So if you are giving a drug and you're having no effect because the animal is overriding it for some reason, and you give more of the drug and have no effect, and you give more of the drug, you're going to have, because at some point this drug is going to be distributed back into the tissues, you're going to at some point get an additive and possibly a toxic effect. The other thing to know about drug distribution are there are barriers in particular tissues that tend to retard or slow the movement of all or certain classes of drugs into them. For instance, the placenta is a good barrier to some drugs that could be toxic to the fetus, but it does permit the passage of others. So you need to understand when you're giving a medication, does it cross that placental barrier? There are anesthetics that do not excessively depress a fetus, and those need to be chosen when we're doing a C-section. So they're generally we want to go primarily straight to gas anesthesia as quickly as possible, or give a real short-acting sedative, a mild sedative, so it's not going to affect those babies. Um, there are other barriers. The other one is the blood-brain barrier. It's not really a barrier. It is whether the capillaries in the brain are typically not very holy. In fact, they don't have a lot of places where drugs can go in and out of them. But with the blood, and so that's a normal blood-brain barrier, and that will usually, it's minimally permeable to all drugs, but it does become permeable to antibiotics if it is inflamed, because it just kind of opens up those pores a little bit. There is a defect in the P-glycoprotein drug transporter in the blood-brain barrier in several dog breeds, so that makes those capillaries more leaky, and these are collies, old English sheepdogs, Australian shepherds, Shetland sheepdogs, and English shepherds. The eye and the prostate also have a barrier that impedes some drugs from diffusing into its tissue. So it's harder to get drugs into bone, prostate, eye, brain, and placenta, or through the placenta to the fetus. Drug absorption. So the disease processes can interfere with drug distribution. We talked about the GI system and how an inflamed intestine can cause a problem with that. Antibiotics don't diffuse well into abscesses or exudates, so they don't go into the tissue that is infected because there's usually a barrier or a thickened wall around those infections that the body tries to wall off and keep it from the major organs of the body, and so antibiotics usually don't diffuse well into them. So typically with abscesses or exudates, we need to clean them out and treat them topically. Heart failure and shock because of decreased blood flow can reduce tissue distribution of the drug. Kidney failure or uremia can alter the plasma binding of some drugs like furosemide or phenylbutazone. Liver failure causes a reduction in the amount of protein or albumin that is available for protein binding. So that's going to leave more free drug to circulate through the tissue or through the plasma. Some believe that reptiles have a renal portal system that can distribute potentially toxic levels of a drug to the kidney if the drug is injected into the posterior 1/3 of the body. So we always want to give it in the pectoral muscles or in the arm muscles. Biotransformation. So we did absorption, distribution, now we're on biotransformation or metabolism. It's the body's ability to change a drug chemically from the form in which it was administered into a form that can be eliminated from the body. Now sometimes it actually transforms the drug into a form that can be better used by the body. So that is one mechanism to give a drug that is absorbed and then transformed and then reused. Most biotransformation occurs in the liver because of the action of microsomal enzymes found in liver cells, those hepatocytes. These enzymes induce chemical reactions that render a drug water-soluble, allowing its subsequent elimination in the urine. Once a drug has been biotransformed, it's called a metabolite. Some of these metabolites are usually inactive, so they're excreted, but in some cases they can be active. Active metabolites then recirculate through the body and are distributed to tissue where they have their action. For instance, Pepto-Bismol has an active metabolite, which is aspirin. When Pepto-Bismol is metabolized, part of it turns into aspirin, and then it can have a negative effect on the GI tract if we have ulcers. A few highly lipid-soluble drugs are incorporated into the bile and are eliminated through the biliary system, which takes it into the feces. But most are excreted through the kidney. Some biotransformation does occur in other tissues, such as the kidney, lung, and nervous system, but most often we're going to see it in the liver. There are 4 chemical reactions that are induced by microsomal enzymes in the liver to biotransform drugs. The first is oxidation, which is the loss of electrons. The second is reduction, which doesn't make sense, right? But it's the gain of electrons. Hydrolysis is when a drug molecule is split and water is added to each of the split portions. So H2O is added to each of the split portions. That's hydrolysis. And conjugation is when glucuronic acid is attached to the drug molecule and it becomes much more water soluble. So again, a drug that is water soluble is much more likely to be excreted. Now, there are animals, a species, which doesn't make a lot of glucuronic acid, and so they do not excrete drugs as quickly. And if you remember that, you'll know that cats tend to have a lot more toxicities to drugs, more susceptible to certain drugs. Biotransformation. Many factors, including species age, nutritional status, tissue storage, and health status, can alter drug metabolism. Cats have a limited ability to metabolize aspirin, narcotics, and barbiturates because they don't have a great ability to form glucuronic acid. And I just said glucuronic acid is used with conjugation to make it water soluble. Young animals also have a poor ability to biotransform drugs because their liver enzyme systems are not fully developed. Old animals have a decreased capacity because their liver enzymes could be impaired. Malnourished animals with fewer protein raw materials available or if they have liver disease and don't have the protein necessary, then they cannot biotransform those drugs, and the drugs will remain in the system and become toxic. Most drugs are metabolized by the liver and then are eliminated from the kidney from the body by the kidneys via urine. They can be excreted by the liver through bile and the intestinal tract, from the mammary glands, from the lungs, and the sweat glands, and salivary glands, and skin. An understanding of the route of excretion of drugs is very important because alterations or diseases of a particular organ can reduce the capacity to excrete the drug, and a toxic accumulation can result. For example, the anesthetic agent ketamine can cause serious central nervous system, meaning the breathing slows, depression in cats with urinary obstruction because the kidneys excrete the drug. If the kidneys cannot excrete the drug because it's obstructed, then the ketamine will become toxic, get to toxic levels in the body. There are 2 ways that kidneys excrete drugs. So the first is glomerular filtration, just like we filter everything else in our kidneys. And we need to remember that the glomerulus and its corresponding tubule is that individual functioning unit called a nephron. And so that glomerulus is the sieve that filters drug molecules and all other molecules out into the glomerular filtrate and eliminated as urine. You remember this, okay, our glomerulus and our Bowman's capsule and our duct, and it's surrounded by all of these vessels, and it's absorbing and resorbing and all of this through the proximal convoluted tubule, the proximal descending limb of the loop of Henle, through the ascending limb of the loop of Henle, out the distal convoluted tubule to the collecting duct. The second mechanism that kidneys use to excrete drugs is through tubular secretion. So this is where glomerular filtration happens. This is where tubular secretion happens. In some instances, drug molecules can be reabsorbed out of the glomerular filtrate and back into the tub through tubular reabsorption. It is important that the nephrons, glomerulus and corresponding tubules, are healthy and that they have an adequate blood supply so they can do the effective job of excreting metabolites. The lower urinary tract, bladder and urethra, must also be functioning normally, so all of that stuff can be eliminated. If any part of the system from the glomerulus to the urethra is compromised or diseased, toxic levels of the drug may accumulate. The liver excretes drugs by first incorporating them into bile, into the gallbladder. It's eliminated in the small intestine. Then the drug may become part of the feces and eliminated from the body, or it can be reabsorbed in the body and through the bloodstream again. So that's a recirculation. The liver excretes the drugs here, okay, into the bile, and into the gallbladder, through the bile duct, and into the small intestine. Some drugs can pass directly out of the blood and into the milk. Through the blood into the milk from the mammary gland, so we do need to be aware of that, especially if an animal is lactating. And we want to be very careful with animals that are lactating that we're collecting the milk on because we want to watch for drug residues. Any residues found in milk, eggs, or meat product are potentially dangerous to people because they can. Someone could be allergic to the drug, so they could eat meat that has amoxicillin in it, and if they have amoxicillin allergy, they could die of anaphylaxis. Or if we're given prolonged exposure to these antibiotics, they create bacteria that are resistant to these antibiotics. And some of these drugs can cause cancer in humans. Drugs that convert readily between liquid and gas states, like a gas anesthetic, can be eliminated from the blood through the lungs. These gas molecules move out of the blood and into the alveoli of the lungs to be eliminated in expired air. Drugs that are given orally and are not absorbed readily out into the intestinal tract then are passed through the tract and can be eliminated through the feces. Some drugs are eliminated through sweat and saliva, although these routes are not clinically important. The rate of drug loss from the body is estimated by calculating the drug's half-life. The half-life is the time required for the amount of drug present in the body to be reduced by 1/2. And typically, we look at that half-life as a time in which we need to re-administer the drug. So what is this half-life? We have blood concentration, and we have time in hours, and the concentration, the peak concentration is 40 micrograms per milliliter. So half of this is gone at 2 hours. So at 20 micrograms per milliliter, here's my half-life, okay, 2 hours. It decreases another 50% pretty quickly an hour later, okay, but it does take us an hour to get to the peak concentration. So when we give the drug to the time where it's 50%, after it's reached its peak, that's 2 hours. Pharmacodynamics is the study of the mechanisms by which drugs produce physiologic changes in the body. So pharmacodynamics is how does it affect the body. Drugs can enhance or depress the physiologic activity of a cell or a tissue. Drug molecules combine with the components of the cell membrane or with the internal components of the cell to cause alterations in cell function. So this is where we talk about a receptor on the cell and how the drug affects it. So we talk about agonists, we talk about partial agonists, we talk about blockage or antagonist. Okay? If a drug molecule fits exactly into a cell receptor, we call this an agonist. It is causing the same act that a normal process in the body would cause with that cell. Now, it may increase that act or it may decrease that act, or it may be inhibitory, it may be stimulatory, but it's like a lock and key model. If it partially fits in, but not completely, we may have some action of that cell. It's not completely stimulatory, not completely inhibitory, but we have a partial fit. If it's something that fits in but blocks the action of that cell, that's called an antagonist. The tendency of a drug to combine with a receptor is called affinity, and the degree to which the drug binds with its receptor helps to determine the drug's efficacy. The efficacy is the degree to which the drug has an exact fit to the receptor or produces the desired effect. A drug with a high level of affinity and efficacy causes a specific action and is an agonist. It binds it and it opens the action. It's the lock and the key. Okay? If a drug has less affinity and efficacy, it's partial agonist. When it binds, it will partially open the lock. When a drug blocks another drug from combining with a receptor, it's called an antagonist. These are also what we use for antidotes. The combining of a drug with its receptor causes a particular drug action, and this interaction produces a particular drug effect. Some drug effects would be stimulation, or we could inhibition or depression, irritation, and sometimes cell death. Sometimes a drug replaces a substance that is missing or is in short supply in the body, so it's a supplement. When we look at pharmacodynamics, we want to see a dose-response curve to display the relationship between the dose of the drug and that body's response. We should see as the dose increases, we're seeing a response that matches it until we have a maximum response or plateau. No one drug produces one single effect in the body. Everything is connected. So we will have interactions, we will have side effects, and it will just depend on the physiology of the body and the pharmacodynamics of the drug. Some examples of this: low doses of a narcotic can be used to treat patients with diarrhea because if you give a narcotic, it slows the GI tract. Higher doses may be used for pain relief, and even higher doses can depress the respiratory system. The potency of a drug is described as the amount of a drug needed to produce a desired response and is represented by a position along the dose-response curve. The efficacy of a drug represents the degree to which a drug produces its desired response in a patient. Once the efficacy level of a drug has been reached, increasing the dose does not improve the effect. How many people do you know that take an amount of medication and say, well, that worked, but I bet I can get it to work better, and so they take more? That's not how it works. Okay, so you need to follow those dosages, and once we've had that max efficacy level, we can't improve on that. The therapeutic index is the relationship between a drug's ability to achieve that desired effect and its tendency to produce toxic effects. So I'm going to take more of that drug because I want more of an effect. Well, now I can get a toxicity. The therapeutic index, this is a ratio, okay? It's a ratio between LD50 and ED50. LD50 stands for lethal dose of 50% of the animals that this drug was administered to. The effective dose is the dose at which this drug was effective for 50% of the animals. So the LD50 is the dose of the drug lethal to 50% of the animals in the dose-related trial, and the effective dose is the dose of a drug that produces the desired effect in 50% of the animals in a dose-related trial. So the way that we calculate that is therapeutic index is LD50, that number, that dose, okay, could be 20 mg per kilogram, divided by the effective dose. The effective dose is 10 mg per kilogram. So 20 divided by 10 is 2. So 20 divided by 10 is 2. Our therapeutic index is then 2. If our therapeutic index is, the lethal dose is, say 50, and the effective dose is 10, then our therapeutic index is 5. So which do you think is a safer drug? The one where the lethal dose was 20 mg per kg and the effective dose was 10 mg per kg and the therapeutic index was 2, or the drug where the lethal dose was 50 mg per kg and the effective dose was 10 mg per kg and the therapeutic index was 5. The safer drug is the drug that has the higher therapeutic index. There's a bigger gap between the lethal dose and the effective dose. Okay, and here's some more examples. So lethal dose 10, effective dose 5, our therapeutic index is 2, whereas our lethal dose of 200 and our effective dose of 25, then our therapeutic index will be 8 versus our drug C, which is lethal dose of 300, effective dose of 100. Our therapeutic index is 3. So the safest drug is the one with the highest therapeutic index, or drug B. So the larger the number that's produced by dividing LD50 by ED50, the greater the level of safety. Drugs that have a really narrow margin of safety or a low therapeutic index, that means that our LD50, let's get my pointer here, our LD50 is here and our effective dose is here. Do you see how narrow that is? And we're looking at this on a graph, okay? Or if our lethal dose is up here and our effective dose is here, we call that a wide margin of safety. Okay, so this is a narrow margin of safety. Our TI will be decreased. This is a high margin of safety, or a wide margin of safety, increased. We have to be very, very cautious and get just the right dose to prevent toxic or fatal effects with this low, narrow margin of safety. This is talking about drugs that used to treat therapeutic index. Any altered pharmacologic response, this is a drug interaction, any altered pharmacologic response to a drug that is caused by a presence of a second drug is called a drug interaction. The normal response to drug may be increased or decreased as a consequence of this interaction, and that interaction could be beneficial or harmful to the patient, so we need to know how they interact. It can be a pharmacokinetic interaction, meaning one drug changes the way that the other drug moves through the body. It can be pharmacodynamic, in which one drug blocks the action of that drug at the cell, or it can be pharmaceutic. How do we give this drug? Are we giving this drug appropriately? If we give sucralfate and we give another drug at the same time as we give sucralfate, we won't be able to absorb that other drug. So pharmacokinetic drug, again, plasma or tissue levels altered by the presence of the other, and it's changes in absorption, distribution, metabolism, or excretion of the other drug. Metoclopramide, for instance, hastens drug, this is Reglan, hastens gastric emptying and promotes the delivery of drug to the small intestine for absorption. So that's a good thing. So if we want to get metoclopramide, we're going to get another drug to small intestine, we want to give it with metoclopramide. Calcium and tetracycline are a big no-no. We don't want to administer them at the same time because calcium binds the tetracycline, and so the complex is not absorbed. A pharmacodynamic interaction is when one action or effect of one drug is altered by another, and this happens at the site of drug action. So this is when we have a reversal agent like an alpha agonist like xylazine is reversed by yohimbine. Or we have an additive effect where CNS depression is increased with combinations of pre-anesthetics. Or it can be synergistic when we have a sulfonamide drug matched with a trimethoprim drug that helps each other work. A pharmaceutic interaction occurs when a physical or chemical reaction takes place as a result of mixing drugs in a syringe or other container. For instance, diazepam, Valium, something you use all the time when you're doing a pre-medication, can precipitate if you mix it with certain drugs, and it does so more over time. So you never want to mix Valium with another drug and leave that syringe on the counter for a length of time. You want to mix it and give it. Ampicillin furosemide can be chemically inactivated if mixed with an acid medium. So if you're giving ampicillin to your kid, don't have them take it with orange juice. So ampicillin plus orange juice is a bad thing. It's generally recommended that mixing of drugs in the same syringe or fluid administration system should be avoided unless you know you can do it, that the drugs are compatible. When two drugs that are metabolized by the liver are given, one should anticipate there will be a drug interaction. Concurrent use of drugs from the behavior modifying category can cause problems such as serotonin syndrome or hypertensive reactions. So they can be very dangerous because of the way they interact within the CNS. Here are some really common drug combinations that have undesired consequences: antacids with tetracycline or calcium with tetracycline. We get reduced absorption of tetracycline. Most antacids have calcium in them. Ketoconazole with digoxin, cyclosporine, or tricyclic antidepressants decrease the metabolism of the object drugs. Sucralfate with anything really, but primarily with fluoroquinolones, will decrease the metabolism of fluoroquinolones in the liver. Fluoroquinolones with theophylline will decrease the metabolism of theophylline. And we will know what all these drugs are here shortly. But omeprazole, so save this slide because you may want to come back to this later and go, oh, omeprazole with ketoconazole and itraconazole decrease the oral absorption of the object drugs. If we have phenobarbital, if we use it with theophylline, doxycycline, or beta blockers, it will increase the metabolism of those object drugs. Cimetidine will decrease the metabolism of diazepam and theophylline. Tetracyclines will slow bacterial growth and inhibit penicillins that are most effective against rapidly growing bacteria. MAO inhibitors affect a lot of object drugs. It leads to the dangerous accumulation of amitraz, selective serotonin reuptake inhibitors, tricyclic antidepressants. So it leads to serotonin syndrome or a hypertensive state. If you have any questions about this, I highly recommend that you go through this lecture on your own, make some notes, and start your flashcards. And we'll talk about this in class.